All right, well, thank you very much. Thanks, everyone, for staying. It was a beautiful talk by my friend earlier. Again, it's a pleasure to share the podium with you and so many other wonderful people. What I'm going to do over the next 30 minutes is talk about a simplified approach to craniofacial vascular malformations. And I want a special thanks to Steve Kasten, who's from the Department of Surgery at University of Michigan. He gave me many of these clinical slides. And when we talk about vascular malformations of the head and neck, it can really be confusing because these are just some of the terms that are often discussed. Hemangiomas, strawberry hemangiomas, nevus flammis, so on and so forth. And it can really be confusing, but what I'm going to focus on specifically are the craniofacial vascular malformations that involve the head and neck. And this really dates back to the work that was done in the early 1980s. And this really is the summary slide. And when we talk about vascular malformations in the head and neck, there are two primarily types. One are referred to as hemangiomas, and we'll discuss these. And then we have the vascular malformations, and we'll discuss these as well. The main thing to understand is that hemangiomas are proliferating lesions. They have endothelial turnover, whereas vascular malformations tend to be more static. There's no aggressive turnover of tissues. Now, when we look at hemangiomas, years ago when I first started and I put this talk together, there was really, our understanding was there was only one type of hemangiomas. But what's happened in the last classification of the systems is that they've identified different types of hemangiomas. So if you have a hemangioma, they can do a metabolic analysis where they look for glutamine. And if it's glutamine positive, this is what's referred to as an infantile hemangioma. And typically, these infantile hemangiomas arise in infants, so that's how I have to remember it. And the classic infantile hemangioma enlarges in size, and then it completely involutes. So that's the classic infantile hemangioma. Another hemangioma is referred to as a congenital hemangioma. And the congenital hemangiomas arise in the fetus, so actually in birth. And if that hemangioma after birth rapidly involutes, this is what's referred to as a RICH, R-I-C-H. So when we look at this diagram and we see this hemangioma arise in the fetus and then it involutes, this is what's referred to as a rapidly involuting congenital hemangioma. But if that hemangioma that arises in the fetus does not involute and continues, this is what's referred to as a non-involuting congenital hemangioma. So it can be a little confusing, and all of the congenital hemangiomas are glutamine negative. So this is the summary slide of what we'll talk about. But the key thing here is from an imaging standpoint, we really cannot separate these out. But from a biological natural history standpoint, this is how the natural progression of these different types of hemangiomas. And the key thing is as to whether or not they're glutamine positive or glutamine negative. So when we talk about hemangiomas, this is the most common, if you will, tumor in childhood. They're a little bit more common in females than in males. Oftentimes they're solitary versus multiple. And as I mentioned before, they're biologically active. So these are little hemangiomas that arise in kids. And if you're not looking at them, they can be quite ominous. They look quite dangerous. But in actuality, these are benign lesions. As I mentioned before, the most common infantile hemangiomas should involute. So they present as Harrow patches at birth. As I mentioned, there's rapid growth at 2 to 4 weeks. And histologically, this is associated with endothelial turnover. They then go through an involuted phase, and 50% involute by the age of 5 years old, and about 70% involute by the age of 7 years old. Oops, there we go. Oops, this thing's starting to drop. That's okay, though. We'll figure it. I got it. No problem. And this is an example of a rapidly proliferating hemangioma, and this is an example of an hemangioma that involutes. So we can see here it's nice and juicy red, And here we can see it's being replaced by fibrosis. So that's what we see on pathological exam. So what do we see on imaging? This is a classic example of a small little hemangioma here that's involving the right nasolabial fold. Sorry about that. Let me get this. There's a little bit more room up here. There we go. Just 1 second there. Thanks. So here we have a hemangioma here that's involving the right nasolabial fold, and this is a very large hemangioma that's extending posteriorly. And the classical example here is that we can all see this robust enhancement. So the proliferating phases of hemangioma, we expect to see lots of enhancement. Now this is an example of a hemangioma in a child that's involving the left side of the neck. Now you can look at this, and there is a differential diagnosis on this. You can say, well, is this a rhabdomyosarcoma? Is it a tumor? Is it, what is this exactly? Well, first of all, on clinical examination, the referring physician probably has a high degree of confidence that this is a benign lesion. And why is that the case? Because when they perform palpation, it's nice and soft. If this was a large rhabdomyosarcoma, this would be very firm. So clinically, they're suspecting something benign. So how do we analyze this from an imaging standpoint? When we look at the T2 weighted image, is this high signal or low signal on T2? It's high signal on T2. So remember that, because we'll talk about that later. On the non-contrast T1 weighted image, is it intermediate signal, high signal, or low signal? Well, I'd say it's intermediate signal, okay? Because when I say low signal, I'll show you what I mean by low signal in just a little while. And then when we give contrast, what happens here? It enhances with contrast. So we have something that's high signal on T2, intermediate signal on T1, and enhances with contrast. But within this, now we have these small little areas. And what signal are those small little areas? Those are low signal, and those are flow voids. So when we look at a hemangioma, and we see flow voids, this tells us that this is in the proliferating phase. Does everybody understand that? So when we start to differentiate different vascular malformations, it's really, I think, important for us to understand the typical appearance of a hemangioma. And here's another, sorry about that, here's another example. Here's another example of a hemangioma. So on T2 weighted image, we can see it's high signal. And if you look at the central part of the hemangioma, what are we seeing here that's branching out? This is a what? A very large flow void. And then when we give, sorry about that, this computer's giving me a little bit of a problem here. We'll figure it out. So this is what I showed before. This is the T2 weighted image. Everyone can see this. The non-contrast T1, we can see this intermediate signal, and everyone sees the flow void. And then when we give contrast, what happens once we give contrast? It enhances with contrast, right? So that's a typical appearance of a hemangioma. And if we see flow voids, we know it's in the proliferative phase. Another example of a hemangioma, high signal on T2. We can see the flow voids. On contrast, it enhances. Very, very large flow voids. And when we do the flow-related sequences, this is a gradient echo sequence, we can actually see flow within the hemangioma. So this tells us it's a high-flow lesion. Now what about in this particular case? This is another example of a hemangioma. But what's happening here? Do we see any flow voids? So if we have a hemangioma and we do not see flow voids, that tells us that the hemangioma is beginning to involute. Everyone understand that? So flow voids mean proliferation. The absence of flow voids are indicative of an involuting hemangioma. So that's the summary of the hemangiomas. Does everyone get the hemangiomas? Now let's talk about vascular malformations. So when we talk about vascular malformations, these vascular malformations do not have any type of endothelial proliferation. They tend to be static lesions. And vascular malformations are divided into 4 flavors. You could have capillary vascular malformations, lymphatic malformations, venous malformations, and arterial malformations. Those are the 4 types. And as we'll see here, we'll go over each different type. And then once we understand each individual type, we can take it to the next step and talk about the more complex malformations. So the first vascular malformation that we'll talk about are the capillary malformations. So capillary malformations tend to be really discolorations of the skin. We see a little bit of increased capillary flow here involving the skin, and this particular case is in the V1 and the V2 distribution. So anybody remember the type of phacomatosis this is typically associated with? Sturge-Weber, exactly right. So all of you know this type of vascular malformation. This is the typical capillary malformation that we see in Sturge-Weber. This is the most famous capillary malformation. Anybody old enough to remember this man? Gorbachev, right? So we all remember Gorbachev. And the capillary malformations, sometimes we refer to this as a birthmark. These are low flow, and they can be extensive or they can be localized. So from an imaging standpoint, we really don't have to image capillary malformations. In general, capillary malformations are very superficial, they're cutaneous, and in this particular case, we did do a contrast-enhanced T1 weighted image, and we can see the subtle linear enhancement that we'll see in a capillary malformation. So again, imaging is usually not indicated, but I wanted to emphasize the fact that if we do give contrast, we can see the linear enhancement, and in a little while you'll see why that's important. So that's the capillary malformation. The next malformation that we'll talk about is a lymphatic malformation. Now, I'm an old man. And I hate to say this, but I trained in the last century. Isn't that terrible? In fact, I trained in the last millennium. That's terrible, right? So everyone is young in the audience. Maybe there are a few people here of my vintage, not too many. Everyone looks so young out there. But when I learned about lymphatic malformations, we called this by a different name. But does anybody remember the different name we called it by? It starts with a C. A cystic hygroma, exactly right. So this used to be called cystic hygromas, but the current nomenclature is lymphatic malformations. And so this was that term cystic hygroma that we used to use. We don't use it anymore. Lymphatic malformations typically arise in young children. About 75% are located in the head and neck. And histologically, they will classify this still as microcystic, macrocystic, as mixed, but I let the pathologists make this classification, and that's really not our specific role. Now, this is the typical appearance of a lymphatic malformation. On T2 weighted image, it's high signal, right? So this is what we saw in hemangiomas, right? But on a T1 non-contrast image, is this low signal or intermediate signal? What's that? Lower signal. And when we give contrast, does this enhance? It does not enhance. Those are the key features, right? Because everyone can look at this and say, of course, if I see this, it's a lymphatic malformation. But in real life, when you're trying to differentiate this from a hemangioma, both hemangiomas and lymphatic malformation have high T2 signal. So that's why it's important that we look at the other sequences, look at the T1 weighted sequences before and after contrast, and then evaluate the internal structure to see if there's enhancement and to see if there are flow voids. Does that make sense to everyone? Okay. Another example here of a lymphatic malformation. Here it's low signal. This is just a part of the submandibular gland that we see on the opposite side. In this case, it's very, very high signal on T2 weighted image. If you want to say that these are very, very large cysts, we could probably postulate that this is a macrocystic lymphatic malformation, but again, I leave that up to pathologists to decide. Now, lymphatic malformations, another example here, and the importance of imaging is not only can we make the initial diagnosis, but we can also guide how these lesions are treated. Because lymphatic malformations do not contain blood flow, and therefore the type of treatment for lymphatic malformations is typically sclerotherapy. So the importance of imaging, and one of the reasons why imaging has grown so much worldwide, is not only do we make the diagnosis, but we are now basing the management based on what we say on imaging. So we talked about capillary, we talked about lymphatic. The next type of vascular malformation is a venous malformation. And this is what we see clinically in a patient with a venous malformation. So what's a venous malformation? It's actually the most common systemic vascular malformation. It's associated with abnormal veins, and from an imaging standpoint, this is what we look for. We look for an abnormality that typically involves the muscle, and we look for phleboliths. So the other name for a vascular malformation in the head and neck was called a cavernous hemangioma. So what we refer to as a cavernous hemangioma, and sometimes you'll refer, the most common retroorbital lesion we called a hemangioma, that's actually now felt to be a venous malformation. It's not really a true hemangioma, it's a venous malformation. So how do we make the diagnosis? Now what I'm going to show you are the classic forms of a venous malformation. So does anybody see the venous malformation here? Is it at A, B, or C? C, exactly right. So what muscle is this located in? And what space is that in? Thank you very much. Okay, you remember that. It makes me happy. Okay, I appreciate that. So we see the abnormality here involving the left masseter muscle. And then when we look at the T2 weighted image, it's high signal. Now you can look at this and you can say, now hold on for a second. We have now a mass here that's high signal on T2. So this could be a hemangioma, but it'd also be a lymphatic malformation. So how do we know that this is probably not a hemangioma? Because it doesn't contain flow voids. And in general, hemangiomas don't involve the muscle. How do we know that it's not a lymphatic malformation? Again, lymphatic malformations tend not to involve the muscles. They tend to involve different spaces and extend into different spaces. When you see something like this that involves the muscle, then that tells us that we're probably dealing with the venous malformation. Does that make sense to you? So that's that intramuscular component. And when we give contrast, we can see that there's actually delayed enhancement within the venous malformations. Okay? So it's sort of similar to the hemangiomas that occur in the liver, right? Again, I haven't looked at a liver MR in a while. We have an expert in abdominal radiology in the front row here. I consider the brain and the liver accessory organs to the neck, but this type of delayed enhancement can also be seen in hemangiomas involving the liver. Now here's another example of a venous malformation. So here we have the malformation involving the parotid gland, but we can see a component of this involving the posterior aspect of the masseter muscle again. So if I see something like this that's extending into the muscle, this tells me that we're dealing with a venous malformation. And here on T2, we can see this area here is essentially intermediate signal on T1, and we can see it's low signal on T2. What do you think that low signal is due to on T2? It's due to what? Blood products, right? So this is all blood products. Again, telling us that it has some type of blood flow within it. And this is just an example of a venous malformation here that's involving the left masseter muscle. See this on the delayed enhancement? We can see the slow diffusion of contrast extending into the left masseter muscle. And this is the other characteristic of a venous malformation. So we have a venous malformation that's involving the muscle, but what's the other characteristic finding that this venous malformation has? It contains what? Phleboliths, right? Perfect. So the two criteria that we look for in venous malformation is number one, it's located in what structure? Muscle, and it contains your English is very good. Yeah. Shukra. So remember with venous malformations, there's slow flow. It doesn't have the high flow that we typically see in other more vascular structures. So this is a low flow lesion. So if we identify the low flow, then this will be treated with sclerotherapy. So again, the role of imaging is twofold. It's initial diagnosis, and it's also to help triage these patients. Then the fourth vascular malformation that we see is arterial. So when we have an arterial malformation, typically what we look for is a large artery and a large vein, and this is an example of a carotid cavernous fistula. So here we can see arterialization of the superior ophthalmic vein in this angiogram. So here's a conventional angiogram, and we can see arterialization of the superior ophthalmic vein. So this is a very, very high flow lesion, and this is what it looks like on CT. So on CT, if you look in the cavernous sinus, we see something abnormal here, and we also see this very, very large dilated serpiginous vascular structure. And when we give contrast, this is a CC fistula with a lot of enhancement in the cavernous sinus, and we can see the superior ophthalmic vein enhancing. So this is as close as we get to a true arterial vascular malformation. So what we have here are the four types, right? So does everyone remember what a capillary looks like? It looks like a what? It's a birthmark, right? The lymphatic malformation looks like a bag of water, right? What are the two characteristics of a venous malformation? Muscle and phleboliths. And the artery, very, very high flow and enhancing. Everybody understand that? Okay, now let's take it to the next level because you guys are so smart. Ready? Now what we can do is that we can combine these two. So now you can have an artery and a vein, and if you see this, this is what comprises an arteriovenous malformation. So what does an arteriovenous malformation looks like? Well, we're all familiar with this. We see multiple enlarged flow voids. Now, one of the things that I run into is that if we see something that looks like this, oftentimes this is called a hemangioma. But it's not a hemangioma because why? It's high flow, which can be in a proliferative phase of a hemangioma, but the hemangioma also contains what? It also contains a lot of soft tissue. Think about an arteriovenous malformation. An arteriovenous malformation is a direct communication between an artery and a vein. What's missing within an artery and a vein? The capillaries are absent. What's the purpose of capillaries? The capillaries provide nutrients to the surrounding soft tissues. So normal capillaries will perform their normal functions and it allows tissues to grow. But if you have an arteriovenous malformation, the capillaries are absent. So if the tissue cannot receive its nutrients, what's going to happen to the tissue? Is it going to grow or is it going to shrink? It shrink, exactly right. So in this particular case, we see these huge flow voids involving the floor of the mouth. But what about the soft tissues? Are these soft tissues larger or smaller along this? They've shrunk, right? They've shrunk, and that's why the majority of this tissue here is all vessels. And if you look at the opposite side, there's no bulk disease at all. So with arteriovenous malformations, what we look for is dilated arteries and veins, but the surrounding tissues should have shrunk because the nutrients are unable to be passed on to it because there's no capillaries. Did I explain that right to everyone? Everyone's good? Okay. Another example here, this is an MR, and if you look at the MR, this is of the larynx, and with the leap of faith, can I convince you that there are multiple dilated vessels here, and when we do a CT scan, with the CT scan, look at this robust enhancement. This is just a huge arteriovenous malformation that's involving the larynx. And let me see, I don't know if this is going to work or not. We will see if this works. Yes, it does work. So this is a very, very large abnormality here on the gradient echo sequences. Thank you for your computer, by the way. She's ignoring me. Thank you for your computer.
No virus.
I hope I enjoy the virus I put on your computer. So when we give contrast, and this is the trick sequence or the dynamic MRA sequences, we can see robust enhancement. And then when we do perform embolization, this is pre-embolization. Everyone see this? You really can't make out the anatomy. But after embolization, we can now see restoration of the normal flow. So that was an arteriovenous malformation. Now what if we combine lymphatic and venous? And now we can have, this is what's referred to as a veno-lymphatic malformation. So what's a veno-lymphatic malformation? Well, think about it. In this particular case, does this look like an artery or what type of malformation does this look like? Venous, right? Because we have something in the muscle and we have something that probably represent phlebolytes as well too. So this is an example of a venous malformation, but this also contains some lymphatic fluid in it, so hence the term veno-lymphatic malformation. But the key thing is that we remember that it has the phlebolytes and it's in the muscle, so a component of this has to be a venous component of this malformation. Another example here, we have this large area, high T2 signal, and we also contain here, these are multiple phlebolytes extending into the muscular flow. Again, this is a low flow malformation. There are no flow voids within this, so as a result, this can be treated with sclerotherapy. So we have the ability to make a complex diagnosis, and we also provide appropriate triage for treatment. And another example of a veno-lymphatic malformation, we know that sometimes these lymphatic malformations can sometimes present with a rapidly expanding mass. And the reason is because these contain oftentimes blood, and if you have any type of rupture of the blood into the lymphatic malformation, they can rapidly expand. And here we have the air fluid levels that we see in this veno-lymphatic malformation. The next thing that we'll talk about is that if you combine capillary and lymphatic, now you have the capillary lymphatic malformation. So what do you think this would look like? Would this be high signal or low signal on T2? On T2. It will be high signal on T2. And then what type of enhancement would you like to see? Lots of enhancement or just linear enhancement? Ah, you guys are so good. So here's an example of a mass involving the left parotid gland and its high signal. And can I convince you there's small little tiny striations within this? And then this is non-contrast T1. And when we give contrast, can I convince you there's little small enhancement? So this is a classic example of a capillary lymphatic malformation. And I can tell you the pathologists really aren't aware of this classification as they should be. In fact, I can't tell you how many times where I've put this in my report and the pathology then comes back exactly what was in my report. So I'm not getting lucky. I think they really aren't trained in this classification. They're trained in various histochemistries and so on and so forth. And really, I think with us as radiologists, if we understand this, we can really help direct them. Now, what if you have a combination of 3, or what if you have a combination of 4? And this is what we refer to as a mixed vascular malformation. So if you have 2, you can combine the names. But if you have components of all 3, then we just refer to this as a mixed vascular malformation. So here's a large vascular malformation involving the tongue. We can see here on clinical and radiologically. We can't separate this out, so we'll use the term mixed vascular malformation. Another example here, we have linear enhancement here, probably a capillary component. We can see that it's low attenuation, involves multiple spaces, so there's our lymphatic component, and it also involves various muscles, so there's also a venous component. Does not fall into a single category, so it's appropriate to call this a mixed vascular malformation. Another example here involving the retroorbital area, we can see areas of high T2 signal. That tells us that we're dealing with a lymphatic component. When we look at the enhancement here, that's a capillary component and it's involving the muscle, so there's probably a venous component, a mixed vascular malformation. And one more example here. It looks pretty ugly, right? We look, my gosh, this has to be a rhabdomyosarcoma, right? Well, it's high signal on T2, low signal on T1, give contrast, and what do we see on CT? Phleboliths. So those phleboliths help us say that this is not an aggressive rhabdomyosarcoma, but if you understand the basics and understand the characteristics, you can make the diagnosis of a mixed vascular, right on time, perfect. You can make the diagnosis of a mixed vascular malformation. So in summary, what I wanted to do was talk about hemangiomas, and remember the difference between infantile and congenital and the natural progression. We talked about the different types of vascular malformations, and then if you remember this like the Olympic rings, you'll always be able to identify the more complex types of vascular malformations. So thank you very much for your attention.